This is Jason Wall with the Division of Medical Marijuana. We're just waiting for Dr. Wiebe. He got hung up. He's the chair of the committee, and as such, we need Dr. Wiebe in the room to formally kick the advisory board meeting off. In the meantime, I just want to make sure the three board members that are online can hear us okay and can come off of mute. I'll do them one at a time. Representative Westland, able to hear us okay?
Yes, I'm here. Thank you. I can hear.
Okay, Senator Roars?
Here, and I can hear you.
Very good. And then Jake, how's it on your end?
Yep, I can hear you guys as well.
All right. Thank you, you three. Appreciate you doing that. When I ran over, they said Dr. Wiebe was just 2 minutes out, so apologies again in regards to that. We're just in a little bit of a hold pattern here, waiting for him to arrive. And Dr. Wiebe just walked into the room, so.
My apologies for being late.
So Dr. Wiebe, as chair of the committee, we're just going to have you with the agenda to start off the meeting.
So you'll need to call the meeting to order, and then we'll follow the agenda. The first thing I would recommend you do is we'll nominate and appoint a vice chair. So,
Okay. Good morning, everyone, or good afternoon, and welcome. We called the meeting to order. I know that it's kind of that's the first time we meet, so we'll go through some functions, and then we will appoint for the vice chair. So we'll start.
My name is Casey Newman. I'm the Chief Operations Officer for Pure.
Oh, I'm Julie Wakethorpe. I'm the Director of Food and Lodging for the North Dakota Department of Health.
I'm Tracy Breyer. I'm a physician assistant. I've been 18 years. And my daughter and I were advocates for the
Could everybody in the room speak up a little bit? It's very difficult to hear.
Hello, everyone. My name is Leslie Sutherland. I'm your pharmacist. It's a pleasure to meet you. I practice in Fargo, North Dakota. And I think I also work at Moorhead Green Goods Dispensary. So I know a little bit more about the Minnesota side than the North Dakota side at this point, but I'm eager to learn and
My name is Lydia De Jesus. I am just a private person representing the user. I've been an advocate of cannabis for several years now, but since being diagnosed with cancer, I made the shift to user.
I'm Allison Hicks. I'm actually with the Office of Attorney General. I serve as General Counsel to the Department of Health and the Division of Marijuana, so I advise legally.
So we'll move to the ones online. If you want to introduce yourself, I can see one on camera.
I'm Senator Kristen Ross from District 27 in South Florida.
Okay, I don't know whether you can see us here in the room. Welcome. Oh, okay, Representative Westland.
You guys are still very difficult to hear.
Representative Westland, if you want to introduce yourself, please.
Yes, I'm Greg Westland, Canada, North Dakota, represent District 15 relatives at Bismarck, farmer, businessman.
Okay, welcome.
And then Jake is your last one on.
Okay, Jake, you want to go ahead and go?
Yeah, hello, fellow members. My name is Jason Asban. I'm a dispensary manager over there. I have I have extensive knowledge of dispensary operations. Also, I try to educate the patients as much as I can, and I help navigate.
Okay, super. Thank you, Jake. Okay, so first order of business is to go through positions or kind of like officers of the board.
Correct. So statutorily, Dr. Levy is the chairperson of the board, but given that he may not be able to come every time for continuity of the board, I would advise that you appoint a vice chair. You don't handle really any money or anything, so a treasurer is unnecessary. However, this is a board. I would recommend that are they going to do the minutes? But the department does the minutes, there's no point.
We can seek volunteers or nominations for vice chair. Those online are also included.
I love.
Sure, okay. Anyone else other than Lydia? Fine. Person?
Everybody's breaking down the doors.
Okay. So that being the case, I think we could do voice vote. Okay, voice vote. Anyone who's support of Lydia becoming the vice chair of the board, say aye.
Aye.
Any opposed?
People online didn't vote.
Okay, people online.
Aye.
Aye.
Okay, so are these opposing? Okay.
So Lydia, you want to come to most of the meetings then?
Absolutely.
Yeah. Okay. So,
Thank you, Lydia.
You're welcome.
So next item would be kind of like going through the roles of the advisory board, responsibilities, as well as kind of some of the org structure and all the good stuff that we'll be handling from now on.
Allison's going to take care of the roles and responsibilities for the board.
So this is a statutory advisory board. So really, there's not a lot of decision making. There's not really a lot of authority vested with the board. Thank you for putting my legal disclaimer up there, Jason. I really appreciate that.
That was for my PowerPoint presentation.
I really enjoyed that you already just put that up there without me even having to ask. So basically what the advisory board is going to do is you guys advise the department in how they implement the medical marijuana program. Obviously, kind of the main framework has been implemented. It already was, so we kind of have something working. But I kind of foresee this group more as a what's working, what's not, does anything need to change type of advisory group, which you guys then, with the input of the Department of Medical Marijuana, can propose changes to the department. Most of those are going to be either through administrative rule or legislatively, so depending what that is. You guys may receive reports from the department on the status and activities of the medical marijuana program. It's kind of going to be up to you. What do you want to hear about? What reports do you want? Do you, not really care about another action? Don't really want to use your time on that? Is there something you're really interested in? That type of thing. And then you can provide recommendations to the department and legislative management on the medical marijuana program. Again, not a lot of authority to do any actions. You guys are advisory, so it's mostly just making suggestions for changes or improvements to the program, which the department will then take, or legislative management may, take the reins on something if the department hasn't yet. And then those bodies will be responsible for the actual implementation of the change. So really kind of an advisory board, and you guys are going to kind of set the parameters on what do you want to hear about at meetings? How often do you want to meet? Kind of the nuts and bolts. What do you guys see your role as? Because fairly wide open in the statute.
Allison, can you cover public meeting?
Yes.
That area.
So even though you guys don't have a lot of authority, this is still a public board. And so you guys are subject to open meetings and open records. Obviously, there's going to be some exceptions for the legislative members on the board. It's still a public meeting, but obviously communications with them may fall under different rules depending on the context of that. But basically what open meetings are is the public has access to hear what you guys are hearing. They have the ability not necessarily to interact and participate, but they do have the ability to hear what's going on, who's making decisions, that type of thing. The only exception and the caveat is that medical marijuana program is heavily confidential depending on what type of information you may be hearing. So a lot of the information specifically with the private vendors may be confidential. So we may need to use executive sessions for that, again, depending on what you guys decide you want to do. But the grand majority, like you guys were kind of warned before we went live on YouTube, is the stuff you say in this meeting, the materials you reference. Like if you say, oh, I have this report and it tells me X, Y, and Z. Well, now you've just pulled the report into the public sector, and now that's become an open record. So the department will take care of noticing things. The big thing that you guys need to be concerned about, and I don't know, really, there's not enough members of one specific entity to be concerned about it, but if, say, Casey and Tracy and Leslie and Lydia decide to go to lunch, and they want to go to lunch and they want to talk about what are we going to talk about at the advisory meeting? What do you think about this one thing? What do you think? If you span a quorum, now all of a sudden you are violating open meetings because there may be a quorum of the board talking about your public business. Again, I think it's fairly unlikely given there's a good diversity of individuals on this board, but it's just something to be cognizant of if you guys are at something, medical marijuana lobbying informational seminar or something, just a forewarning. Really try not to talk about public stuff with other people on the board outside of the open meetings kind of format. In regards to records, anything that you generate related to this board is a public record. So if Tracy sends an email to Julie asking a bunch of questions about, what do you think about this? What do you think about this? It's not a violation of open meetings, but now if somebody wants to request a copy of your email correspondence, that is a public record. It does not matter if you do not have a government issued email address. It does not matter if you are using your private email, your business email, if you sent it at home, if you sent it to your brother, someone not on the board. If you are writing it or receiving it about your public business, it is a record of this board. So just be cognizant in your communications, and you're also obligated to retain some of those records depending on what the department's record retention policy is. So just be kind of careful. Even though you're an advisory board, you are a board, and you were appointed statutorily. So just kind of be aware of some of those things as you move forward and start conducting board business. That's really kind of the bare bones of it. If you have additional very specific questions, you can certainly talk to me. You can email me, however you want to do that, and I can advise you on specific situations. But just be aware that you are subject to open meetings and open records.
I'll go talk to boards the first.
Not an advisory board. Not an advisory board. No, you guys don't have any decision-making authority, so there's not really a lot you can get sued for. It's basically like, congratulations. Ultimately, you don't have a lot of decision-making power. You're just an advisory board, so we'll save the risk management deal.
I will get all the losses.
Yeah. We now get all the lawsuits. Good job.
So should we move to some program information and kind of updates? I think Jason will provide this.
Yes, thank you, Dr. Weeby. My name is Jason Wall. I'm the director of the Division of Medical Marijuana, and first and foremost, I want to thank everyone for submitting an application to be on the board. I know that everyone is very busy and has a lot of other things on their plate. So on behalf of the division as well as the department, we do thank you for your service and your time in relation. We look forward to working with everybody on the board to help with areas where the program may need to be better. I would tell you that the division is always looking for ways to make the program better and is open to ideas and suggestions from all parties involved on the board. Really, this meeting is kind of an orientation type meeting of the board. Since you were appointed a little while ago, we wanted to make sure that the board got together. You're able to hear from Allison in regards to roles and responsibilities and questions that you have, and also kind of give an update, kind of talk through the program to start identifying kind of the major areas of program operations to perhaps help identify areas where a board member may be interested in either receiving more information at a future meeting or having a further discussion on to make it just looking for possibly a way to consider a different way to approach a specific topic. So that being said, for those that are watching online, the PowerPoint presentation, I think you're going to be able to see, but this PowerPoint presentation is available on the Division of Medical Marijuana website. So if you just go to health.md.gov/mm, and under the presentation and annual reports link on the left side of our homepage, you will be able to find this PowerPoint as well. I'm going to jump right into it. As Allison pointed out here, as I talk, I am certainly not an attorney. I usually have a couple good lawyer jokes I use at this part of the presentation, but since Allison is sitting close enough to throw something to hit me with, I'm going to skip those jokes and move on to right into the program information here. So, there it went. Actually went too fast. I think I skipped over one. There we go. So in relation to, there's a little delay, so sorry about that. In regards to the Department of Health, this is an organizational chart for the department. I should make the advisory board aware that the Department of Health, through a statutory change this last session, will be merging with the State Department of Human Resources. Human Services, sorry. Human Resources, jeepers. Human Services. I hope nobody from DHS was listening, but I can't even get our merger buddies name right. So with the Department of Human Services, and that needs to be effective September of next year. So the Department of Health is going through, so this organizational structure, obviously we'll see some changes, but I wanted to show the board currently where the Division of Medical Marijuana sits. So if you look at the Department of Health org structure, third from the right, you'll see licensure and certification. That is where we fall under. As you can see, it's the State Health Officer, Dr. Weeby, a Chief of Staff, Dirk Wilkie, who is online on this meeting as well, and I think a lot of you have met Dirk in the past. Dirk is also the section lead in regards to licensure and certification, so we are very fortunate that we actually have a direct reporting line to Dirk Wilkie. Julie Wagendorf, who's here on the advisory board from Food and Lodging. Julie and I are obviously under the same area in regards to that. The other thing I'd point out about the structure of the department, as you'll see on the next slide, we're a very small division, so we rely on a lot of assistance and help from various people throughout the department. We are very fortunate that we have other people to rely on. And starting over from the far left under administrative services, Brenda Wise, our CFO, has been very supportive, and we have used her and her team throughout implementation and are very fortunate that we had such good cooperation in implementing the program and getting the program to where it's at. Setting up the meeting, even we had Clint helping us out in our licensure section. Darren Meshke, who's the head of Vital Records, is also our IT person. He was relied on heavily, and we thank him for all of his help and assistance as well. So we do, because of our small staff, even though you'll see Division of Medical Marijuana, we really don't get things done without the help and assistance from a number of different areas throughout the department. So. And here comes one of the smallest org charts you'll probably ever see in state government in regards to what our Division of Medical Marijuana looks like. So we have 5 full-time equivalents. The Division of Medical Marijuana is fully supported and pays all of its expenses through the fees that are collected in the program, whether it's application fees or the certificate fees. All of that money is deposited into a special fund. We have a continuing appropriation in law for those monies, and that is what pays all the expenses of the division. No general funds are used for the program. We did have general funds available the first biennium, and after that, now the program has been self-supporting. So really 2 sides to our org chart. It's really the compliance aspect with dispensaries and manufacturing facilities. You'll see compassion center language anytime. I'll try not to say compassion center too often. That's really a manufacturing facility and a dispensary. So I usually try to say both just to make sure it's clear who I'm talking about. On the right side, we have 2 individuals that do all the inspections, reviews of the 10 entities that are registered in the program. On the left side, our program administrator, Renee Sisk, who is also online here, responsible and oversees the registration side. And I'll talk about all of these a little bit more here in regards to the program as well. And pending reclassification is our admin individual, Donna Dahl, who is sitting here to my left. As we're doing reclass in regards to that position, as really Donna does a lot more than just admin type administrative work, and is really important to the processing of our applications and kind of keeping the other 4 people in line with what we're supposed to be doing on a daily basis. The 2 individuals on the right are actually traveling today. They're in Fargo, so we're unable to attend the meeting today. When we talk about the medical marijuana program, there's really 2 areas where the regulations or the requirements for the program exist, and it's either in North Dakota Century Code or North Dakota Administrative Code. Keep in mind, North Dakota Administrative Code, that is particularly Representative Westland and Senator Rohr's area. Legislative Assembly modifies those laws, so once every 2 years, there is an opportunity for law changes to occur. North Dakota Administrative Code, a lot of times you're going to hear that referred to as administrative rules. These are set up through an administrative rule-making process that's initiated by the Department of Health. We are looking at some drafted administrative rule changes, and once we probably get that administrative rulemaking process started, we would look at coming to this board to discuss those drafted changes and kind of talk through and have a discussion and take any input and comments from this board on those as well. You'll notice if you ever take a look through North Dakota Century Code and Administrative Rule, we are very heavily dependent on definitions. Definitions are an integral part to implementing the program. Part of that relates to the fact that this is still a federal illegal drug. And as such, we're very particular in regards to the language that we use and terminology we use to a certain extent to stay out of the federal government's radar. The more that we just don't have things occurring and that we know the federal government really doesn't like in relation to these programs, able to stay off their radar is best for the program and for the state of North Dakota. So I'm not going to read every definition you see here, and it's really only 2 slides. We just want to make sure you have this available for you to always refer back to and use if something were to come up, or if I keep saying the same term and you're wondering what is that guy keep talking about or saying, you're always able to go back and take a look at those definitions. For those in the room, this one might be a little bit hard to read, and my apology for that. The medical marijuana program for the state of North Dakota really started through an initiated measure back in November of 2016. Tracy mentioned being involved kind of from the beginning of the program, and actually Tracy has been on various committees, review committees on applications throughout the program implementation. So Tracy knows the program very well, has been, I think, involved in manufacturing or dispensary, all the dispensary application reviews. Tracy was on that committee, as well now as being on the original advisory board and now this new advisory board. So this gives you an idea of what took place. The 2017 legislature did suspend implementation of the program, and until that law was finally passed by the legislature in 2017, that's really when implementation of the program and the clock kind of started ticking for the Department of Health to get the program up and running. This kind of, you can see where things fell in relation to a time period. First dispensary opened in Fargo in March of 2019. And by the end of that calendar year, the remaining 7 dispensaries also were open. State law does identify a maximum number of manufacturing facilities at 2 and up to 8 dispensaries. So really the program to us kind of became fully operational in December of 2019. And I should have said, if any board members have any questions, comments, need clarification on anything, please just unmute yourself there, and here in person, just yell out and interrupt me, please. Happy to answer any questions the board may have. So I mentioned before that, marijuana is still a federal illegal drug. There is a lot of talk at the federal level right now that we do get some updates on periodically in regards to where that's going. That may have an impact on the program for the state of North Dakota. But at this point in time, we still have a federal illegal drug that the Department of Health is required to implement a program to dispense to qualifying patients. We do not have any reciprocity with other states, meaning that if, for example, the state of Minnesota has a medical marijuana program, Minnesota medical marijuana card holder can't come into North Dakota to make a purchase of products. There was a bill regarding reciprocity before in front of the legislature that was defeated. Certain other states do accept a North Dakota card, so a North Dakota patient could go to that state and make a purchase. However, they would not have any protections under the medical marijuana law if they were to bring any of that product back to North Dakota. Early on, we did have a number of calls with law enforcement where law enforcement was running into patient or registered qualifying patients in North Dakota having products from other states. So we tried to get as much information to law enforcement that under the medical marijuana law, they have no protections. What law enforcement does with that is a law enforcement decision. We don't tell law enforcement what to do in those cases. It's up to them to decide in their state's attorney what actions they are or will not take. The dispensed product not to cross state lines, and also the patients are informed that they need to make sure that their dispensed product stays in the container with their labels attached. That offers them the protections under the medical marijuana laws. This is a very quick overview in regards to the process as to how an individual becomes registered under the program. Typically, if somebody is interested in the program, the first person they probably talk to is Donna. And Donna sets them straight and tells them exactly what to do. And if we could get 99% of those people to do what Donna tells them to do, we'd be in a great position. Fortunately, we have multiple conversations with individuals. One thing that has been very fortunate for us is with all the dispensaries open, we're able to direct people to those dispensaries, and dispensaries offer assistance and help with the application process. They're able to, help them get registered. If they don't have a computer, they'll offer them a computer or an iPad or a laptop to sit down and kind of enter information into the system as well. Ultimately, in our program, an individual can become registered as long as they complete all the necessary information, and a healthcare provider completes what's called a REGISTRY certification. If we have a complete application and they pay their fee and a healthcare provider has completed it, the department's required to approve that application and issue what's called a patient registry identification card. Really, medical marijuana card is kind of what that's known as. That's the language in the law. So you may hear me say medical marijuana card. That's their registry identification card. For an individual to be able to qualify for the program, they do have to have at least one debilitating medical condition. These two slides, I'm not going to go over everything in here, but these are set in state law, so this is a legislative decision. This past legislative session, there were no changes to the list of medical conditions. The session before, in 2019, there were a number of additions to the list of medical conditions. Representative Westland, it feels like I am yelling to make sure that you're able to hear me. Can you hear me okay, or am I too loud, actually?
No, I can hear you fine.
Okay, now I'll keep talking with my outside voice. Excuse me. Here's a chart that's in our fiscal year 2021 annual report. State law does require an annual report to be completed on the program. So if you haven't had a chance to review the annual report, they all are out there on our division website. Contain a lot of information in regards to the program, and kind of you can see where trends exist and other data and information that state law states should be in that report is provided. You can see by this chart, at that time, there was just over, there there was just over 5,700 registered patients at this point in time when the start would have been derived. Healthcare providers can check more than one condition on the written certification, and a number of them do. Obviously, if there's 5,700 patients, we had over 10,000 conditions listed, it happens very frequently. We see a number of applications with more than one medical condition selected. You can see anxiety disorder is the number one medical condition that is selected. Anxiety disorder was added to state law in 2019. When I talked about definitions and terminology, one thing that we stress a lot is that in this program there are no prescriptions. Healthcare providers do not issue a prescription for the medical use of marijuana. What they complete is a written certification. That written certification has to be completed either by a physician assistant, or an advanced practice registered nurse. They have to be licensed in the state of North Dakota. At the time that they complete that written certification, that is part of our verification work, is ensuring the healthcare provider who completes the written certification does have their license with the appropriate medical board in North Dakota. So you could have a healthcare provider in Minnesota or South Dakota complete written certifications as long as they're licensed here. Part of the requirement for signing a written certification is to complete what's called a bona fide provider-patient relationship, or they have to have a provider-patient relationship. This screen just identifies the main areas of what is required in regards to that being met for a healthcare provider to complete a written certification. In the 2019 legislature, I should say, excuse me, we did identify to the legislature that there were a number of individuals that use the federal VA system for their health care. Since this is a federal illegal drug, that primary health care provider for those individuals had no means to take part of the program. So a law was passed that provided a reasonable accommodation where a veteran that were able to gather information to ascertain that, yes, the federal VA is their primary health care provider, were able to obtain their medical records and a copy of information that's requested, and then able to use that information for them to become registered. As of last week, we did have over 250 of our qualifying patients are using that veteran accommodation. So how do we implement a program of a federal illegal drug and still able to say that with only a staff of 5, we have a very well-regulated program? This is the slide that allows us to do this. Really, we rely heavily on our IT system. We use BioTrack THC. They were selected following a competitive procurement process with the state. And we have been very fortunate that our IT system has, knock on wood here, has worked as well as we could hope in dispensing products and making sure that products that are dispensed have passed compliance testing, that products are only getting dispensed to registered individuals in the program. So thankfully, through the use of IT, we've been able to maintain a staff of 5 FTE and still regulate the program as we'd like to see it regulated. There are 2 sides to our IT system, a registration side and a traceability side, and I'm going to talk about each of those in depth a little bit more. Excuse me. You can tell that COVID has been a long time. I haven't done presentations for a while. My voice is going to give out, or maybe I need to yell at my kids more. So, on the registration side, we do have online applications only. There isn't a paper application. We started with that upon implementation of the program. And looking back, that was a very good decision that I think we came to. in regards to this is it definitely saved on staff time filing, and also from a risk management standpoint, that we're able to have the electronic system and the vendors responsible for the storage of the information. Individuals do create an account in that system, and it's just their email and a password. We were able to get a law change in the 2019 legislature that allowed us to accept electronic payments. So now we can take electronic payments for the application fee for qualifying patients and for agents or those that work at manufacturing facilities and dispensaries. One nice feature on the registration piece is applicants, if they do log into their account, excuse me, they are able to monitor the status of their application as it's being processed. And once they are approved, we do right now still print out a printed card, but they also have an electronic card that's available to them in their account. An individual who has been registered can actually monitor their purchases in their account electronically. There is a 30-day limit that we'll talk about here in a little bit. So they are able to monitor through the system where they're at in regards to their number of purchases for dried leaves and flowers and the other medical marijuana products. We require each of the 8 dispensaries to verify that card every time they come into the dispensary to make sure that it is still valid. That is done through an actual scan of the card, the barcode that's on the back, or a QR code that's available electronically as well. Law enforcement does have the ability to enter in the card number where they can verify the name and the status of that card as well. So this individual, I assume, will be sending us a nasty letter one day when he realizes when he sold his picture, he became the face of the medical marijuana program. Because I'm sure he never thought that when he sold it to the AP or whoever he sold it to, that he would end up as our sample patient. But here's what our printed cards look like currently. It might be a little bit hard to read, but the top part is the front of a card. And on the back side, there's information that we added for law enforcement in the bottom right-hand corner that talks about the dried leaves and flowers. It's either going to be a no, which means it's a minor patient. They don't have access to dried leaves and flowers. The standard amount or an enhanced amount, and we'll get into that a little bit more here as well. So when we talk those registry identification cards, qualifying patients receive a card, a designated caregiver receives a card. Those who work in the industry, manufacturing facilities, and dispensaries have a card, and then also the laboratory employees also have a card for transport purposes, and in case law enforcement were to come into the lab as well. The Department of Health has a contract with a lab located here in the state that goes to manufacturing facilities and selects samples and then does the compliance testing. So here's what we'll break down the card types here as far as the number of cards and give you an idea of kind of where things are at and how they've progressed since the first date that the first 3 ones. So when that first dispensary opened in Fargo, you can kind of see where our card number was below 500 and where we're sitting at as of last week when I put the slide together, we're at just under 6,900. So we would fully anticipate that we'll be over 7,000 by the end of this calendar. The next slide here talks or identifies, information regarding caregivers and then agents. Excuse me. The designated caregivers are the bar on the bottom, and then our number of agent cards have been right around 400 since we got the full implementation. That 8th dispensary opened has been hovering right around 400 for the most part since that time. So an individual who is registered with the Department of Health in regards to having a patient card, here are the types of what law says is usable marijuana. When I used to do presentations for law enforcement early on about the program, law enforcement always used to give me grief about, well, Jason, all marijuana is usable. Why do you call it usable marijuana? I'm like, I don't know, because the law says it's usable marijuana. But what the lawyers were looking for were a term to specifically distinguish. So, by the law, everybody knew what we were talking about in a medical marijuana program. We know all marijuana is usable, we get that, but the way the law was written is it really broke down marijuana for patients into two category types. Dried leaves and flowers, there you can see on the left, and then what's called medical marijuana products. There's two different allotments that are provided in a 30-day period. And this is a rolling 30-day period. It doesn't reset to zero. It's not on a monthly basis. It is specifically on a 30-day amount. In fact, the way the IT system works is it's down to the actual second. So if I were to purchase something right now at 1:55, let's say today, exactly 720 hours later, whatever I purchased comes back on their allotment. That part has been kind of an education piece that we sometimes still struggle with. I think dispensaries still struggle with a little bit every now and then, trying to explain to patients how, your amount that you have, your 2.5 ounces dried leaves and flowers, on the 1st of December coming up here, you don't have a full 2.5 ounces of dried leaves and flowers to purchase again. The system's always looking back at your purchase history the last 30 days. So on the other category, the medical marijuana products, that's where the 4,000 milligrams of THC comes into play, and that's where you talk about your concentrates and then your cannabinoid products. 3 of those 4 cannabinoid products are to market. Transdermal patches are not to market at this point, but we do have solution capsules and topicals. Just recently, we had a roll-on come to market on the topical side that provides them another way to administer rather than having to use their hands, and has so far received very positive comments at the dispensary level about that product type. So very briefly here, just a little bit of information when we talk about dried leaves and flowers, what's on the market today. There's really kind of 3 categories of dried leaf. Well, I shouldn't put it that way. In regards to dried leaves and flowers, if you're going to buy just the dried leaf and flower itself, like actual marijuana, you kind of think of the buds. There's kind of the regular, which is kind of the top grade that comes off the plant, and then there's also a bee bud and trim. Now, bee bud and trim are sold at a lesser price than what the regular dried leaves and flowers amount is sold in. Those come either in a gram, 3.5 grams, or 7 grams. There's also pre-rolls available. And so if you make a purchase of dried leaves and flowers from whether it's regular bee bud trim or the pre-rolls, that's what comes off your 2.5 ounces of the dried leaves and flower allotment that a patient has. The next 2 slides are going to talk more about those medical marijuana products. The first category of concentrates. Here's concentrates that are available out there in regards to the program. We do have vape cartridges. I would point out to the board that the vape cartridges, though, are only containing what is specifically extracted from the marijuana plant itself. The manufacturing facilities do not get to add any artificial flavoring or any other, or vitamin E when the whole vaping epidemic kind of hit. A lot of concerns. We were fortunate enough that we had not allowed anything to go into those vape cartridges other than what comes out of the plant. And when it comes to concentrates, right now we're at 0.5 gram and 1 gram container sizes. Our other products on the market are solution capsules excuse me, topicals and lotions, BNC solutions are now, maximum amount is a 30 milliliter container. Capsules, right now there's 10 capsules per container that are being sold. And then there's various topicals and lotions that I mentioned. Okay. Here are our locations for the registered dispensaries. When the program was implemented, the Department of Health struggled for a long time how to go about determining where 8 dispensaries were to be located. So when we implemented the program, what we did is took the 8 major cities and drew a 50-mile radius around each of them and had an open application period for that region. It said you can put your dispensary as long as it's in that 50-mile radius of that major city. Excuse me. Part of the reason was is because cities have, local governments have the ability to zone out a dispensary. If they wanted and they determined that they didn't want a dispensary to be there, they could have zoned them out. So we wanted to make sure that from a population base that's kind of distributed in a rural state, that locations were so people didn't end up driving 200 or 300 miles to try to get to it. But that's where the locations ended up. They all ended up in those 8 kind of major cities, we like to call them. And we used kind of a phased-in approach when we did this. So the first application period, for example, was for Fargo and Bismarck. And then we had Grand Forks and Williston and did the last 4. Did the last 4 at one time. We have 2 manufacturing facilities, Pure Dakota, which is located here in Bismarck, and Grass Fritz, which is located in Fargo. The manufacturing facilities do all the growing, processing, and producing. Before anything that is transported from a manufacturing facility to a dispensary, it is tested. Has to meet the compliance requirements that are established in the administrative rules. And also the manufacturing facilities do all the packaging. So when it leaves the manufacturing facility, it's already in the container, tamper evident, sealed, and goes to the dispensary. So our dispensaries don't weigh anything out. Dispensaries get the products from manufacturing facilities, and they dispense what they actually receive. I mentioned 2 sides to our IT system. We talked about that registration piece. Here's the traceability piece. So this is really a seed-to-sale system. And when we say we track all parts of marijuana, the full process of marijuana, we believe we capture everything that we possibly could in the system itself. Whether it's a seed or a clone, all the way to it moving into a plant, to the flowering stage, to when it's harvested, to an extraction, and ultimately from manufacturing facility to dispensary, using a manifest system that's set up in the IT system, and then ultimately to dispensed. So when it's dispensed, the system captures and is able to say, yes, that's a registered, valid individual that is dispensed, and it takes off the allotment amount that is actually that product is taking based on size or the total THC if it's a medical marijuana product. Also I've talked about compliance testing a little bit, but just to cover that some more, the lab that we have under contract will go into the manufacturing facility. They will actually take they will transport it back to the lab using the manifest system in the IT system, and then they will enter into the IT system their testing results. That way, it's able to stop anything from going on to a manifest that hasn't passed compliance testing. nice feature that we have in BioTrack and hearing from other states. Some systems don't do that and has created a number of problems and issues in some other states. I should point out that all compliance testing expenses are actually paid by the manufacturing facility. Here's a list of the tests performed. In the administrative rules, there are standards set up for these elements that the lab tests for. Has to be under that threshold in order for it to get transported to a dispenser. When the product comes to the dispensary from the manufacturing facility on the products that contain certain information required by the administrative rules. But also then, once that product is dispensed, dispensaries have to also place on that container and an actual specific label from that dispensary showing that product's dispensed, who it's from, date of dispense. Law enforcement then is able to use that if they do pull something over. They can enter in that barcode number from their medical marijuana card or up the label that's on the box to determine whether that individual has a valid card or not. A couple more slides here, and then I'm sure you're going to be tired of listening to me, so I'll turn it over for any more questions. One area of the law, state law requires that there's an adverse event reporting. So we do have available adverse events that if there's an unexpected or unwanted reaction, there's a form available on our division website for law enforcement, healthcare providers to submit information to us when we get those. Excuse me, obviously they are reviewed immediately to determine or to look for an indication of a possible product concern, or is this more of, in certain cases, maybe an education or a training piece for either the patient and or dispensary to make sure that dispensaries are providing that education to the patients when they purchase certain products. State law also requires an incident report. So we do have available on our website incident report form for law enforcement to complete. This is where law enforcement has maybe pulled somebody over and Joe Smith has Sally Johnson's products and Joe Smith doesn't have a medical marijuana card, or maybe Joe Smith had a medical marijuana card but has Sally Johnson's products. Those are things of concern that get reported to us. We then start a review of that area by notifying the individual, giving them an opportunity to provide us information. And after a certain time period, we do a review of all that information and determine what, if any, additional actions to take against, with the status of that individual's card. I believe this is the last slide on this item, Dr. Levy. As far as program information, just wanted to make the advisory board members aware that in regards to the prescription drug monitoring program, the Division of Medical Marijuana does actually upload a file of current patients once every 2 weeks. So in PDMP, individuals authorized in PDMP are able to look at an individual and see that they have a medical marijuana card and the date that that card expires. Going to make sure, yep, this is the legislative changes piece. So for that item, Dr. Weedy, on the agenda, that kind of takes care of it.
Well, any questions for Jason about this piece of thing?
So each of the sewers have five designated that could buy like respite care or adjuncts to that person's care. Seeing that people have been using all five, or is that rare to see a consumer use more than one or two designated caregivers?
So for those online, Tracy's asking about the designated caregivers. That is something that was changed this last session, was to allow a patient to have up to 5 designated caregivers. Before, it was a one-to-one relationship. That one designated caregiver, there are certain scenarios where that causes problems, whether it's an adult patient that requires 24-hour care, or, in the case of families maybe that are share custody of a minor patient. So the legislature did make the change. That became effective August 1st of this year. Since that time, I don't believe we've actually issued more than one card. There might be some applications submitted to get more than that. But right now, we did make the change to the system, had it ready to roll out and go for August 1 so an individual can add a caregiver. But right now, I don't believe there's any out there. That could have changed since I was looking through some information. Tracy also asked about respite care. We've done some presentations. It's obviously been a lot pre-COVID here in regards to some presentations and actually talked to some groups about that and whether or not they wanted a special designation for hospice, for example, in regards to that. And we kind of told them that, if this is something you're interested in, you let us know and we'll work with our attorney to try to come up with a solution to see if there's a special designation to add. We haven't heard anything since that time. Obviously, a lot of things have happened since then. But it's not something that I've heard about or heard from as much. Basic care facilities, nursing homes, the law talks about there to establish a policy and procedure in regards to how they're going to handle this, and we kind of left it up to those entities we didn't leave it up to them. We always tell them that's their discretion, it's their policy and procedure. Point to the law that talks about that.
So, Jason, for clarification, is the maximum amount, is it per card holder or per patient?
Dr. Weeby and members of the advisory board, it's really based on the patient tied to that card. The system is set up then too with the designated caregiver, as before even the patient comes in and buys. Before they're in their car, the system's already, it's real time, so it's already there, so they couldn't, drive to another dispensary. But the concern was always a patient buys and maybe their caregiver lives in a different city and they going to buy, and all of a sudden they're over there. But it's tied to the patient card itself. All those designated caregiver purchases will all come off the allotment of that registered patient. And I should have mentioned too, you probably saw on that slide, there is an enhanced amount for dried leaves and flowers, and I don't know if I mentioned the enhanced amount has to be authorized by the healthcare provider for an individual, a patient that has a medical condition of cancer. If they have that, then on the application, certification, if they mark cancer, another box, another area populates in automatically where they have to either check the box that I do not authorize or I do authorize them for the.
Hey, any other questions?
Is there any education available for providers, or is there just like a Q&A site? And I noticed on the registration card, it doesn't say the provider's name. Obviously a good thing, and probably a good thing for the provider to know, just as far as it's not on the card.
Right now, Tracy, in regards to, all information is confidential in regards to the programs of healthcare providers. Somebody calls us, so they need to know a healthcare provider. We don't disclose healthcare provider names. Healthcare providers are able to access PDM to determine whether their patient, has a card. If they're wondering, do I have this card? So they're always able to see whether or not that individual CCMP on the card. Sorry, Tracy, I don't think I answered the first part of your question.
Is there education available
Thank you.
for providers?
So on our website, there is a box specifically dedicated to healthcare providers, but it's going to be more education in regards to the process and the written certification and having an account system, more so than the education piece on the medical use of marijuana. The Department of Health doesn't, for the regulatory body, so we don't get that aspect. We leave that to more of the industry, and we point to dispensaries. I am aware certain registered dispensaries or manufacturing facilities as healthcare providers discuss the education side of things. We've done a number of presentations, and we've hit all the major healthcare facilities just to talk about the program, the process. But that one, I don't know if you were at the last one, but I always start those presentations with, we're not here to tell you to complete written certifications, and we're not here to tell you not to complete written certifications. That's truly the healthcare provider's determination. The Department of Health has no approach inherently, specifically, to tell healthcare providers what to do in this area.
Questions from the online participants? We'll move to the 2021 legislative changes.
I promised Dr. Weedy this will be a lot quicker than the last one.
Okay.
So this last legislative session, I'm just going to briefly discuss some of the changes that occurred and also talk about some of the changes that didn't occur as we fully anticipate and expect some of them to come up again because they popped up a couple of sessions in a row. Just want to make sure that the board is aware of those areas in case they want more information or would like to discuss that in another meeting. One change that was made was the legislature did remove the $50 designated caregiver application fee. This was actually brought forth by the Department of Health for a couple of reasons. One reason being that we see a number of patients come into the dispensaries that probably would benefit greatly from having a designated caregiver to come to the dispensary to make a purchase on their behalf. And the second part of that is sometimes we have heard that the designated caregiver fee the designated caregiver process does require a criminal history record check. That costs money as well to submit fingerprints, send to BCI to get a criminal history record check. So it kind of was, they had to pay for that, plus they had to pay an application fee. We'd really like to see the number of designated caregivers come up, so we proposed removing the $50 designated caregiver fee in hopes that more people would be willing to possibly get a designated caregiver. Legislature did remove that, and we appreciate their assistance in that as well. Another change this last session was all application fees and the registration fees were a set amount in statute. And we proposed, instead of it being that you will pay a $50 application fee for your registry or your qualifying patient registry identification card, that it's an up to amount to provide the department the possibility that to eventually look at the possible reduction of fee amounts as the program continues to. Excuse me, we talked about the third bullet there already. The fourth one, the department was aware of certain instances where family members would call in and identify that they had a family member with a terminal illness, that they wanted to try this for them. With the criminal history record check process taking sometimes a long period of time, people struggling to find a place to go get fingerprinted even, especially during COVID, The department brought to the legislature's attention that it may be worthwhile to consider, the waiver of a criminal history record check when the individual has a terminal illness. They agreed, and they did change the law that now we can issue a designated caregiver card without a criminal history record check for 6 months if the patient has a terminal illness. Favor of the fee, then it just made that process a little bit quicker to be able to help out in those scenarios. Another legislative change, there were some definitions that did change in regards to owners and ownerships, the substantial corporate change, and then also a change to THC. Obviously, with this new board, the other change the legislature made was the actual members and representation on this advisory board. So I have 2 slides here that talk about what didn't pass or what didn't end up going forward. One bill introduced related to home grow. Individuals are allowed to grow their own marijuana plants. We've seen this the last 2 legislative sessions. It's been both times. We also saw bills related to some changes in regards to the minor patients. Wanted to remove the pediatric limit and also allow minors to be eligible for dried leaves and flowers, and the legislature voted those down. And then there was kind of a reciprocity temporary card for somebody coming to North Dakota. We weren't quite sure how that was going to work, but that did not pass either. The final 2 bills, and this is where the department probably had the most time on bills that didn't pass and provided information and had a number of discussions, relates to edibles and an adult use program. Edibles, saw this 2 sessions ago as well. This time, the edibles bill, we had a number of discussions with the legislative body in regards to edibles and what concerns in relation to adding edibles were from, getting in the hands of children, or, that all of a sudden we have gummy bears in a medical marijuana program. This edible bill was very specific, that it was to be just a square shape. It had a lot of good language, we believe, in regards to the maximum amount of THC possession limits. That did pass the House, actually, but it failed on the Senate side. It had a simple majority vote of yays, but since this was an initiated measure, any changes to the statute requires a 2/3 majority for 7 years since that date of passage. So while it had enough yes votes for a simple majority, it didn't meet the 2/3. So the edibles bill did not move forward, or did not end up getting passed. The other bill, adult use bill, we would have become the first state to really have a regulated adult use program, meaning we would have had to implement a program where we would be tracking purchases based on some identifier, and this was going to be set on 15 days, strictly the 1st through the 15th, and then the 16th to the end of the month, where there were set amounts that could be purchased under an adult use, or what you probably hear is a recreational program in other states. That did pass the House. It actually passed exactly with 2/3 vote, if I recall correctly, and then it failed in the Senate. So these are the 2 that we've seen the last couple of sessions, and potentially could see again coming up as well. So we wanted to make sure to bring that to the board's attention. Then Dr. Weeby, I promised it would be shorter than the last one. There you go. Much shorter.
So maybe are there any updates beyond this kind of like this? Maybe do we know or have an idea what might come the 23 session, as well as any initiative might be circulating?
Dr. Weeby, would probably leave it to Representative Westland or Senator Morris if they have any ideas in regards to the upcoming session. I'm still trying to get over my nightmares from this past session. So I haven't thought too far into the 2023 session. I would suspect, knowing Representative Westland, and I don't mean to speak for you, sir, that edibles is kind of been something I know there's been a lot of discussion. Representative Westland was on the original advisory board as well in regards to that, and also with the edibles bill.
I will work on it again. I can guarantee you that. You can convince the Senate to pass it.
I've tried and tried, Greg. I've tried.
I know you did.
I thought you two were going to arm wrestle.
Yeah, we're certainly going to be working on this. Again, I have no doubt about it. Hopefully this time will be successful.
As far as Dr. Reedy, your other question as far as initiated measures, I'm aware there was initiated measure signatures trying to get collected. I haven't read it. I'm not sure where the status of that even is right now.
I think it's out for circulation, but it hasn't been returned yet. I'm going to guess you're going to see more about recreational or adult use session.
Any other questions to Jason?
Just in like transdermal patches.
Tracy, we haven't heard a lot from patients. It might be, Jake, I still see you there. The question was asked transdermal patches. Jake's on the dispensary side. He might be in a better position to maybe talk about that if he's heard people asking about patches at all.
I've definitely had a couple people inquire about them. Definitely not as much as the edibles and that kind of things, but there's definitely have been a couple different people that have asked about transdermal patches. You know, different people that aren't trying to smoke or ingest anything for sure.
Transdermal patches, what would that be like? That's not like a fentanyl patch. Certainly be useful for those that are, you know, egg tube feedings or pediatrics that can't. The lotions may work a little bit, but I think the transdermal patches would be, I thought was going to be something.
Population that would benefit from that. On a request for that.
Okay. We can certainly have the discussion with manufacturing facilities and take that to them as well. We would say we know patches are difficult. We can definitely say that. We know that from other states too, just with the concerns and issues that they've had with getting those to market as well. And I'm not, cost-wise could potentially be an issue as well. You know, from a simple-minded person, that the patch, you know, if we put something on a Band-Aid and just say we'll put the Band-Aid and let it soak in over time, it's not that simple. We know that and understand that, but it's certainly something we can talk about as well. There are states that have that. And I'd have to go back and look again, last discussion we had, to see how many are out there and kind of get an idea of, you know, what they're using. I know some of them had talked about that. When they first came out, they thought they were very, you know, just a square, but a number of patients were actually cutting them. The amount just was too much for what they were looking for, and they thought they had dosed them at an amount or had them set at an amount that was to that bare minimum, and they ended up finding out that no, it's longer, has more effects on.
Set up for something when you start really, really low, and you know the consumer will have to figure out that's going to take some time.
circle back when you find what the adverse.
Yeah. So adverse event reports come to our office, and if we get assistance, we reach out to one of the doctors in the Department of Health. Obviously, we can always ask Dr. Weedy for his input necessary. Right now, I would say, I'm going to be careful how I say this. We haven't had adverse reports come in that have led to concerns with products themselves. More of a training education piece. I think the industry has told us more than once, so I think I'm okay in sharing that. North Dakota doesn't have a lot of education with patients when they first come into the program. Some states have very educated individuals starting out in the program, even more so than maybe some people working in the industry, or they claim that they do. But we have a lot of individuals that come in that are really first-time marijuana users who really need an education. That was part of the reason, Leslie, why we wanted counsel built in every dispensary to have them. We see consultation rooms. We have 24-hour access, live feed access to all 8 dispensaries, both manufacturing facilities. They're required to maintain the video for back to 90 days, so we can always go. But we always like seeing when we pull up a live feed and somebody's in that consult room and the dispensary employees are sitting there with their manuals, with their books. And you'll see people in a consult room for an extended period of time. And I think the adverse reports, I would classify it more as, at this point, not product-related issues or problems, probably more of an education that needed to be. That's what dispensaries. Especially with certain product types that are high THC.
Jason, does your staff substantiate those adverse reaction reports, or do you also depend on like lab testing or perhaps physicians?
So with the adverse reports that we've had to date, we followed up with each of them with our staff, patient and or healthcare provider, depending on what it was. And usually through the discussion with the patient, we're able to identify what is actually taking place or what has happened. And we use that information, and if we're not able to do that, then a discussion with the healthcare provider can be held, because that's, who can submit that information necessary. Then it would be and, or it could be an or, because we weren't able to talk to the patient.
Since this is the first time we meet, probably we'll spend a few minutes on the cadence of the meetings, as well as topics. So we'll kind of like, the discussions and the topics being discussed here will be based on the interest of what us as an advisory board want to hear or want to be exposed. So we'll kind of spend a few minutes on that. So with the meetings, is there a minimum number by statute?
So it's however frequently.
So that would be up to us to decide on the frequency, the length of the meetings. I think quarterly meetings.
I think 3 or 4 times a year would be appropriate for this group.
I was going to say quarterly as well.
Okay. Other thoughts? Do you think quarterly? Or is it
2 hours maximum.
2 hours maximum, 4 times a year?
Everybody in the room here very much.
So since we are kind of meeting on the end of November, let's kind of start on a 3-month cycle. So that will be the end of February, and then we can send the invites so they are on your calendars ahead of time, so then you can plan around the time. So it would be 2 hours, and this kind of like Mondays is a good day, or 1 to 3, to have something recurring every Monday that preclude you from attending.
I think last time it worked out well for her to send out a couple possible dates and then allow us to vote a little closer to that time, because my schedule changes just based on what else is going on.
Okay, so we are kind of like, you are suggesting that you do not schedule the 4 meetings at this time, but as we get closer towards the first quarter, we send some kind of like a poll to see the time that works best.
It works for me.
Okay, that would work. Okay, so we'll do it this way then. Okay, so that was easy. So let's kind of think, next meeting, are there topics or items that you think you would like to discuss, or kind of like maybe Jason to get some data or information on, anything that you hear from people in communication with, or whether constituents, or whether kind of, citizens?
I think, Jason, you know how in this last session we were able to kind of remove the, for lack of a better term, HIPAA issues for you. So what is some of the maybe trending data that you'd be able to provide to us? What are the most, you were able to show kind of the types of reasons why people are on, but what are some of the other things? Is it, is there a way for us to know what's the most commonly, type, the buds and flowers, that kind of stuff? How is that trending? And then any other just common questions and issues that you get, because I think some of those might help, especially Greg and I, as we work our way into the 2023 session, assuming we're both there. What are some things that we could do to continue to improve the program? And then I think from the industry side, what are the things that they're seeing? And so just making sure that we're seeing from the patient side, the producer side, the dispensary side, and then from the legislative side, and what you guys from the administrative side, what we can do to help with that.
Thank you, Senator Rourke. I'll make sure we'll look at some additional data. We'll run it by Allison to make sure that we're still within the confines of that law and don't require an executive session. I would say that I haven't had a chance to talk to Allison. The last committee, I don't know if you heard anything from the Judiciary Committee, receives the annual report. And in that committee, it was, how best do I describe it? They wanted some more information. I couldn't give it to them. They weren't happy. So I know I have to meet with Allison before their next meeting. A lot of sales data, sales information, for example, they wanted to have tax information, things like that. And I said, with that change this last session in regards to providing data, we just are always careful with what we provide and run it by Allison before we release it. So I'll meet with her prior to the next board meeting here and put together some more charts, data that provide to the board for their review. Dr. Ruby, yes. If I have a question that Melissa on your topics, is it okay when send out the meeting date? Potential here's 3 topics to add to the agenda. We're okay.
Conversation by biologists.
I don't know, did everyone hear that online?
So in other words, if you have any additional topics or items you would like to bring for discussion, advisory committee here, then send that topic to Jason.
And I think, Dr. Reedy, what we'll do is, how the meeting typically will get set up, since Dr. Weedy's the chair, we work with his admin person to try to find 2 or 3 dates. I thought my calendar was full until I sat down, and for 2 months, literally in a 2-month period, he had 2 dates of 2 hours or more available on his calendar. So I will never complain about my calendar ever again after working to try to get something on Dr. Reedy's calendar. But when we send that out, we'll probably just ask for a topic you want on the agenda. Just don't hit reply all, and it's set up to not be able to hit reply all, but just reply back with the topic, and I think we'll be okay. Topic or topics, that there's more than one.
About the distribution of the diagnosis, with the anxiety being like, and I know like if Dr. Weeby and I are filling out the written certification for these consumers, and if we see the word anxiety, we're going to check that like 99% of the time, because we know if we check more of the boxes, that substantiates why the consumer needs the product. It's to know if that's true, that 99% of us that are filling out the written certificates are anxiety. That's an easy one, but don't want that information to be misconstrued that there's anxious people. That's one of the ones that we mark on any kind of diagnosis, substantiate why the person needs it.
Thoughts or topics you would like to be brought forward?
Oh, thank you, Allison. Dr. Weeby, one thing to point out to you and the other board members, depending on the date, but even if we could put into March, there would be a good chance the draft rules available to bring to this group to review and go over, and the comments you would have then we would take into consideration, and then our analysis of those administrative rules.
Oh, that would be a good item to add to the agenda, and then if there is the need is to schedule the meeting March rather than in February. Final thoughts, suggestions, ideas? None. So thank you very much for your time and volunteering to part of this advisory. And adjourn.
Thanks, everyone.
Thank you.
Thank you.
Have a good rest of the day. Thank you.
Okay, thanks.